Getting started with ICB orthotics. In today's modern world, patients present with a range of biomechanical issues, often with the underlying causative factor being excess or overpronation. Weekend joggers and casual runners often think that the modern sports shoe will suffice in being able to treat their overuse injury. However, hard surfaces can cause the feet to collapse as the foot structure adapts to the ground, rather than the ground adapting to the foot, thus allowing the arch to collapse and the foot to elongate. The effect of this is pain and issues to the upper structure. ICB foot orthotics can help to maintain the lower limb's biomechanical structure and avoid or treat many common conditions such as arch pain, heel pain, knee pain, lower back pain. This video will explain how to get started with ICB orthotics in your own clinic. We will outline a very basic assessment and a simple method of treatment, which will use heat to modify the orthotic device to the patient's foot structure. Commence by observing the patient's rear foot positioning. We should determine if the patient is excessively pronating, supinating, or has a bilateral or unilateral issue, such as unilateral pronation. Check the patient's resting position. Correct the foot into the neutral calcaneal stance position and then observe the positioning. To assist in finding the correct molding position when the patient is wearing shoes, use the anterior alignment markings, also called the modified talonavicular method, which marks the anterior reference lines. Doing this will assist in establishing the correct position when fitting the orthotic in the patient's shoe wear. Commence by asking the patient to pronate their foot and place your finger into the depression that sits lateral to the talar's head and anterior to the lateral malleolar. Now ask the patient to supinate their foot and mark that spot like so. That is, opposite to the lateral side. Place thumb and forefinger on either side of the talar head on the two marked out spots. Palpate the bump on either side until you feel that the bumps are even or congruent. At this point, the subtalar joint is in the neutral position. Next, mark the two dots and place a bisecting dot. Mark the second metatarsal head position. Join the bisection and the second metatarsal head. Place a dot on the tibial crest about 1/3 of the way up the tibia. Next, draw a line down the tibial crest along the trough on the lateral side. Align the tibial line with the second metatarsal head position whilst palpating the subtalar joint to congruency. That is, neither excessively supinating nor excessively pronating. This is the position for heat molding the orthotics. The anterior lines can be marked out in either the weight-bearing position or in the supine position. Use the same procedure when using the supine position. Mark talar head position medial and lateral. Bisect the dots. Mark the second metatarsal head position. Mark the position up 1/3 of the tibia. Join the dots, and align for neutral. Checking for structural leg length deficiency. You can check structural leg length at this time to ensure that a leg length issue is not present. Use your normal method for measurements such as tape measure, knee height, or by using a support under the short leg whilst checking the PSIS positioning. In this video, we also give a simple and effective method of assessment using the supine inferior malleolar asymmetry technique, which levels the pelvic cage and compares the position of the bilateral medial malleolar. The method is simple and surprisingly quite reliable. This is important as unilateral long leg can cause unilateral longer leg excess pronation as compensation. Treatment will be to increase the short leg to level the pelvic alignment and reduce stress on the long leg by using a heel lift addition for the short leg. Supine leg length measurement. Commence by leveling the pelvic cage. Mark a line under right and left medial malleolar. Align the medial malleolar and compare if there is a difference. Determining the correct product density. Use the chart to choose the correct density to suit the patient, depending on the severity of the pronation or supination, the weight of the patient, or the presenting condition, such as diabetic or geriatric patient, which will require a softer product. Each density has been manufactured to provide different levels of support. However, the 5-degree rear foot and medial arch angles remain the same for the different densities. Active Pro Density is a low-density product designed for more comfort with corrective ability. Easy Fit Density is low density designed to cater for narrow-last footwear, such as trainers, football boots and fashion footwear. The white density is the softest for patients less than 50 kilos or for geriatric or diabetic patients. The blue density for patients weighing 55 to 75 kilos and for medium pronation. Multicolor is a mid-density designed for children 15 months to teens. Green density is a firm density for patients 90 kilos and above and for severe pronation to provide more control and support. Sports Dual is our original flagship product and is suitable for all-round general use and sporting activities. If you would like to simplify the choices, then you could use the ICB Dual Sports. It has a mid-density in the body of the product to provide a degree of cushioning and a slightly higher density green in the heel and arch to provide more control and support. This product is the most popular product in 2/3 and full length around the world. The new Easy Fit product is a low-density product designed with a contoured narrow last and beveled edges to fit in many shoe designs. The product retains the 5-degree rear foot varus post and has a bulk-free arch and medial flare to contour to the average shoe. Choosing the correct size orthotic and how to trim the product. Choosing the correct size is very important as incorrect fitting orthotics can cause issues such as sesamoiditis, where an elongated arch in the product can impinge upon the first metatarsal phalangeal joint. The easiest way to determine the correct size is to place a 2/3 product on the foot and observe where the distal edge or leading edge sits. The position should be 5 to 10 mm behind the bisection of the first metatarsal phalangeal joint position, as this allows the joint to flex without impingement. It is easy to find the distal edge of the ICB 2/3 product, however, the full-length product will need to be folded back to expose the distal edge as seen in the image and then check that it is the correct size for the foot. Be aware that the full-length orthotic forefoot is just a filler to provide more comfort for the wearer. Some patients wear shoes that are a size larger for whatever reason, so don't just use the shoe brand sizing. Once you have the correct size, trim the product if necessary to fit the shoe by removing the factory-fitted shoe insert. Place the factory-fitted shoe insert or old shoe insole on top of the new orthotic, lining up both of the heels and inside edge. Trace the outline of the old insert onto the new orthotic with a pen or marker. Trim to shape. Reinsert the trimmed orthotic and check and adjust as necessary. Recapping the process. Remove insole. Align orthotic and insole. Trace the outline. Trim. Reinsert into the shoe. Fitting of additions. If you are using orthotic additions, always attach the rear foot and forefoot additions prior to performing any heat molding procedure. Doing this will allow the orthotic to contour to the patient and reduce any orthotic instability in the shoe after the heating process. Non-heat molding, is this okay? At ICB we are often asked, do I always have to heat the product? The answer is absolutely not. If the pronation or supination is minimal, then the angles built into the product will be enough to provide support for the patient in gait. The product may be prescribed for other issues that do not need the heating process, such as adding a heel lift. The product can now be taken out of the Ziploc pack and placed directly into the shoe. Check with the patient over the following 2 to 3 weeks that the product does not require heat adjusting to provide additional patient compliance. Preparing for heat molding. Once you have selected the correct model, size and density, advise the patient to replace badly worn shoes, as these may reduce the biomechanical effectiveness of the product. Make sure the patient is wearing both shoes and socks for the heat molding procedure. The heating process. Remove innersoles, arch cushions and thick linings from the shoe. Ask the patient to wear one shoe with the unheated orthotic. Commence to heat the remaining product by holding the distal edge of the ICB orthotic. Place the heat gun 15 to 25 centimeters away from the plantar surface. Heat for 20 to 30 seconds in circular motion until the product softens, using a 1, 2, 3 circular motion on the plantar surface into the arch area. The words right and left will smooth as an indicator of the right amount of heat. Heat dorsal area and arch and heel area for approximately 5 to 7 seconds on products that do not have a top cover. Do not heat the covered products as this may burn the fabric material, rather, only heat the plantar surface of these products. It is best to reheat, rather than overheating the product. Hold the product in the heel cup with your thumb. Place the patient's foot into the shoe and ask them to stand with equal weight bearing and feet equal distance apart, that is, approximately hip width. When heat molding the patient's left foot, use your left hand to cup around the shoe heel counter and at the same time support the arch area. Use the right hand to depress the first and fifth metatarsal heads to complete a triangular shape, that is, heel, first and fifth, whilst checking that the anterior line is in the correct subtalar neutral position. Hold for 30 to 40 seconds. Ask the patient to sit and remove the orthotic. Allow to cool, then repeat the process with the other foot. Use the same procedure to heat mold the non-heated product. Do not allow the patient to stand on the products after they are molded for approximately 1 to 2 minutes, or until it has cooled after the procedure. Stabilizing the product. Once the orthotic is molded, place on a desk or hard surface and check that there is no rear foot movement. If there is instability, use a rear foot addition to fill the gap and remove any rocking motion from the molded orthotic. Add additions as required, such as metatarsal domes and heel lifts. Suggest that the patient wears the product for 1 to 2 hours at a time and allow the product to settle in for a period of 2 weeks. If irritation occurs, take the product out of the shoe and allow the inflammation to subside. Usually a couple of hours, then continue the pattern. If heel slippage occurs, choose shoes with a high heel cup, or if the shoe is tied across the transverse arch, such as riding boots, choose a low-profile model such as the Easy Fit orthotic or high heel court model, and remember to always take the factory insert out of the shoes. If symptoms reappear, check the density on the prescription guide and if needed, add a medial longitudinal arch addition to support the medial arch. Alternatively, check the density guide and use a firmer density product to provide more support, or add a rear foot varus addition to provide more rear foot control. Is extremely important, so ensure that you fill out all areas and maintain your patient records. Commonly, most practitioners do not use measurements when assessing resting and neutral calcaneal stance position. They just indicate either ticks or crosses to signify what is happening on rear foot positioning. However, it is necessary to measure the structural leg length to ascertain the physical adjustment required for the shorter leg. For large corrections, use half the measured amount and gradually increase over a 3 to 4 month period to the patient's satisfaction. Density should consider both the amount of correction and the comfort of the patient. Treatment should err on the side of more comfort for the patient. Use the Ready Reckoner as a clinic assistant and a visual guide when speaking to patients. For more biomechanical theory, refer to the Orthotic Solution book.